Again, I'll ask people to speak up, unfortunately, if not yell. I think we're safe. We're good. All right, so Little Shop of Horrors, case discussion. Where would you like to start?
Should we start with the eclipse since you mentioned that?
Okay.
As
Yeah.
the segue?
So all of this starts. So, yeah, segueing from our morning film, the discussion of what ails Dolores Claiborne, now to Little Shop of Horrors. We have what will turn out to be an alien triplet that itself connects to Earth through some space or cosmic event. So there is some connection. By the way, we're also connecting to last week as well, in as much as this is our second consecutive musical that we're discussing. That is Little Shop of Horrors, following up our discussion last week of the Rocky Horror Picture Show. So the other thing I wanted to connect to, again, a lot of loose connections, loose associations, but it's worth mentioning. I know, and you don't have to own up to it right now, but I know everybody watched Groundhog's Day on Groundhog's Day. So we're focusing on yet another Bill Murray film this afternoon. Mm-hmm. So with that background and with that introduction, where would you like to start?
Let's start with the Steve Martin's character, the Orin.
Seymour?
Yeah.
No, Steve Martin.
Oh, the dentist.
Orin,
The dentist,
yeah.
Steve Martin's character. So what did you say?
Yeah, definitely a masochist. So, or sorry, sadist, not masochist.
Sadist or sadistic disorder?
Or antisocial personality disorder.
I guess sadistic disorder because it's violating the rights of others and it's like a significant like against social norms.
Yeah. So again, sadism, a paraphilia outside of love, outside of the normative love. But sadistic disorder is sadism that rises to the level of being clinically significant. And if we think that the dentist and his behavior clinically affects self or others, right? Then, yeah, sadistic disorder. Right? And Bill Murray's character might actually be masochistic disorder.
Yeah.
Versus, again, just quote unquote, just masochism.
Oh, Bill Murray, yeah.
Right? So not only do we have back-to-back weeks of musicals, but we have back-to-back weeks of musicals that depict sadomasochism, right? Rocky Horror Picture Show and Little Shop of Horrors. Right? So we're not going to review the paraphilias again this week. Okay? You could listen to last week's recording for that acronym, for that list, and then the highlights of each of those paraphilic disorders to identify it on a shelf exam. Anything else? You also mentioned that I'm going to put words in your mouth, may have discovered a blatant disregard for and violation of others' rights in the dentist's character. And if that is the case, chief in your differential would be a condition called antisocial personality disorder. Mm-hmm. If you're considering this, what is going to be one of the things you would like to investigate at this time?
A conduct. And that is apparent in his song.
Right. So the evidence of conduct disorder prior to the age of 15. Now, this is the only time that is in the evaluation of any personality disorders where we do need a pre-existing condition, in this case called conduct disorder. Every other condition, every other personality disorder can be diagnosed in children. This is the one exception. This is an adult-only illness that is antisocial personality, the only personality disorder in individuals 18 years or older. Hence, the pre-existing condition of conduct necessary for that adult pathology, antisocial personality. Anything else here?
Substance abuse. So he's using the whippets of nitrous oxide, I'm assuming laughing gas.
All right, so how will nitrous oxide and or inhalant intoxication present on a shelf exam?
Agitation.
Marks on like their nose.
Yeah. Tachycardia, like extra sympathetic symptoms, essentially.
There's more.
Altered mental status.
Could altered. What I want you to understand is that the clinical vignette will look almost exactly like an individual who is drunk. If you look at the diagnostic criteria for alcohol intoxication and cross-reference it with inhalants, there's significant overlap. All right? There's two things to look for here. Number one is that, number one would be consistent or characteristic on a shelf exam, earlier onset, whippets, for example, inhalants in general, children and adolescents. Now, that's not to say that children are not going to drink, but characteristically on a shelf exam, younger population. Also, younger onset, earlier onset of neurological sequelae. The individual who abuses inhalants will manifest neurologic sequelae during the acute intoxication phase. That is not the same for alcohol. The neurologic effects of alcohol are long-standing effects, Wernicke's-Korsakoff, decades later, due to the depletion of vitamin B1 diamond, right? So that differentiates. And then finally, euphoria is a diagnostic criterion of inhalant intoxication. That is not the case for alcohol. Alcohol is a CNS depressant. So the individual, of course, I'm sure you've all either experienced or experienced the company of, may become disinhibited. But that's different than euphoric. Right? Euphoria is inhalants. Euphoria is not part of alcohol intoxication. Alcohol, as a drug, has an identified withdrawal phase. Inhalants do not. So there is no such thing as inhalant withdrawal. There's no physiologic withdrawal phase from inhalants. That, of course, is not the case for alcohol. Right. Questions? What are the four subtypes of inhalants?
Solvents, nitrates,
Gases
gases.
and aerosols. Good. Good. Now, DSM criteria, inhalant intoxication, applies to all four. The four differ sometimes route of administration. I mean, all result from the inhalation of vapors, of the solvent, of the aerosol, etc. And therefore, because of the route of administration, may have different physical findings, right? So, for instance, puffing may actually result in perioral erythema, whereas that might not be the case for aerosols. Okay? So that's something to keep in mind. Remind me off camera, I'll give you the stereotypical, very characteristic presentation of this on a shelf exam. Any other observations in our dentist?
Maybe like a mild narcissistic personality disorder, like you have to like be called doctor, like you know.
What's wrong with that?
I don't know, I felt almost like he needed praise.
Or validation.
Yeah.
So the question that you're going to have to ask yourself is twofold. Number one is, remember we just got done discussing the personality disorders and how easiest to identify them. Shelf exam, a clinical encounter. A lot of these, including the narcissistic personality, have an identifiable cardinal trait, right? So is there an arrogance where the individual believes they are special and can be only understood by someone as special as they? Because if the answer is yes, that screams positive. Now, of course, if yes, we have to discuss clinical significance. Right? But that's the kind of barometer I want you to use and that could be something that you glean from the history or even counter-transferring. That your reaction to someone's overbearing, clinically significant arrogance. Do they believe they're special, and do they believe that therefore they can be only understood by someone as special as they are? Because the message you're going to get, Doc, is that it's not you. Right? So if the answer is yes, if that's pushing your buttons as you're watching Little Shop of Horrors and watching this scene with our dentist, then they're screaming positive for you. Right? You have additional questions then to ask. Any other observations? What characters? In addition to our dentist and our patient.
Audrey
Okay. So,
Seymour.
The boss, like dependent personality disorder.
you think Audrey has dependent personality?
Yeah.
Okay.
Could,
So,
potentially.
dependent personality, cardinal trait, yes. All right. So again, and let me emphasize this: the reason why we want to identify these cardinal traits is because the DSM criteria then serve as examples. Much easier to remember them. Right? Every single one of them. Dependent personality, the individual who needs reassurance and affirmation for their every next step. Okay, very difficult to actually take a step without that guidance and reassurance. That's that dependent personality, right? Audrey?
I mean, yeah, she definitely has like elements of dependency. Not like she like can't decide to leave the dentist. She has to like it's basically done for her.
And she like needs someone else to go to.
So
Yeah.
again, rebounders is a diagnostic criterion of this, right? So are you saying that if Seymour had not expressed interest, she would not have thought to break up with it? I mean,
No, I don't think
she had to break up with the dentist because of what happened. Though. But let's say that we'll take Audrey 2 out of this.
Like if the dentist was still alive?
Yeah.
No, I don't think she would have ended things with him at all.
No? Actually, I'm disagreeing.
I think she like feels like in order for her to be complete, she like needs to have like a man. Like even her visions of the future.
Right.
Like there was like it was
Yeah.
like centered around like her life at home with her husband.
I think that was Seymour's song.
Oh, that was his.
Yeah. But yes.
Yeah, they have
but
like
yes,
that.
it's together.
And again, we have to be just very careful in pathologizing this, because if there are other elements or factors that present themselves as to what guides and motivates her behavior, that's got to be part of this conversation before we attribute what we view, what we've observed as a result of a dependent personality disorder. Okay. What else is going on with Audrey?
She's being mistreated.
Yeah, and here we go. So we know that the abuse syndrome does result in what overtly could be misinterpreted as dependency. How many times does somebody hear a story and ask, why do they stay with that person? And that's a very tricky situation in emergency rooms when domestic abuse presents. And the physician or the physician extender believes that by addressing it, that's the course of action, and that's the only course of action. So when the individual says, no, I want to go home, that conversation should not end there, right? So it's a very tricky situation.
It's also like her death is very interesting. Like she wants to, like, she even wants to help people after she dies. Like when she gets injured by Audrey 2, and she like knows she's dying, she's like, I want you to feed me. To like help Seymour. It's like perpetuating that like she needs to feel needed.
That's part of histrionic personality too.
Yeah, I was just thinking she might have some like level of histrionic
Could be.
personality.
Could be. Anybody have the perspective, especially given the name, that Audrey and Audrey 2 are the same person?
That they're like opposites of each other?
No, that there's no such plant that's, I mean, if somebody presented to you, whether it might be Seymour, whether we name the presenting character in your vignette Audrey, if you're hearing about this plant from outer space that is doing what it's doing, I would suggest when you're taking call with me that you consider that it's not reality. And there might be something else going on. And the fact that the plant's name happens to be Audrey, specifically Audrey 2, is there a case to be made that there is no such plant? And that whatever's going on that we believe or that is being reported as a result of this trippid is actually Audrey herself.
It's like a dissociative identity disorder, or like
Yeah.
she's like a serial killer.
Yeah.
I
It's a
never heard.
representation of her id.
Yeah, exactly what it is. It's an
Mhm.
external representation of her id, her impulse. Yeah. I mean, you have to rewatch the film now with that
Yeah.
perspective to see if it fits, but boy, if that is the case, we're not talking about histrionic
Mhm.
or dependent personality anymore. So it's all perspective.
Right.
And again, I would ask that you consider the perspective and put yourself on call, and then calling your attending, explaining what you observed, what your history reveals. That is the plot of this movie, and that maybe there's no such thing as a plant from outer space that's killing and eating people. Additional thoughts?
Maybe like the plant is like an illusion. Like maybe it's not actually a man-eating plant. Like maybe it is a plant, but not like a dangerous plant.
Yeah, so another idea of reference. Did we really come up with this again? Here we are now full circle. We talked about this with Seinfeld, not one, but several characters. Even one that was alluded to in this morning's episode, The Son of Sam, David Berkowitz. Idea of reference. The dog was barking, but the dog was not Satan telling him to kill. That is an idea of reference. Right? Mr. Pitt's lawyer, idea of reference. Again, Mr. Pitt himself, idea of reference. So, and here we go again. Maybe the plant did exist, but to attribute this delusional content onto that real stimulus is an idea of reference.
Mm.
It's a delusional misinterpretation. So, and then that begs the question, whose perspective is the story being told? Who is our psychotic patient?
Right.
And I just throw it out there. I'm not saying there's an answer here.
Right.
Maybe someone who like is killing people and like needs this as an excuse to why he's killing people.
Who's our serial killer in Little Shop of Horrors? I don't know who it is. Again,
Wait, is it Seymour? Is it Audrey? Is it?
yeah, the fact that the plant is named Audrey suggests that it might be Audrey.
But who's last to die? Isn't Seymour like last to die? So maybe
Seymour is last to die.
maybe, like,
Yes.
he kills everyone and then ends it with suicide.
It's worth rewatching, and my gut says is that this is a movie that you watch more than once anyway. So I'm not really putting too much on your guys' plate with this. But it does deserve a rewatch with that perspective and what might be going on here. What about Seymour? If he's not a serial killer, what else might be going on with him that you've observed?
Schizophrenia.
Well, if he's not a serial killer,
Yeah.
Maybe like he's like stuck in one of Eric Erickson's stages.
we're all stuck in one of our stages. So yeah, I don't disagree with that. He's middle adulthood,
Yeah.
so he may be struggling with generativity.
Yeah.
And if he is, and it's being unsuccessfully resolved, you're dealing with stagnation. So he might be in what other people might refer to as a midlife crisis,
Mhm.
aka Ericksonian stagnation, which he does seem to be stuck, job, etc.
It's also like the world in which he's kind of manic. Like he finds this plant, he thinks this plant is gonna like save them all. Like it's a little grandiose and yeah.
Yeah. I was thinking like he could also be like a schizoid or schizotypal personality disorder, just because he's like kind of at the beginning he's like very like keeps to himself, like he doesn't really have like relationships besides like, and he's like fantasizing about Audrey but like doesn't really talk to her, and then now he's having these like odd behaviors and magical thinking with the plant being alive, if that's like how he's perceiving it.
And remind me, in the beginning of this movie, especially perhaps related to his work, is there a stressor that is introduced? Is there?
They're
He
gonna
was
close
like,
the shop.
he was like, yeah.
Right. So if we have an individual who is coming, I think the observation here would be we have a very shy character.
Mm-hmm.
And if we think that this may be, that his shyness may be indicative of an underlying cluster A personality, including paranoid, schizoid, schizotypal. In each case, any individual with any of those pre-existing conditions can actually become psychotic when a measure of stress is induced. And that is referred to as stress-induced psychosis. Right? And that's what might be happening here. He is shy, schizoid versus schizotypal. There's the potential closure of his employ. There's that stressor, and now we see a product of his psychotic system where this plant is discovered that's going to save everyone.
Right.
So maybe Little Shop of Horrors is nothing more than a case of stress-induced psychosis in someone with pre-existing schizoid versus schizotypal personality.
Mm-hmm.
Let's say before the plan arrives, before the onset, the prequel, this individual presents to you with this level of shyness that he identifies as now become problematic because he can't meet anyone. What's your differential in addition to schizoid, perhaps even schizotypal, depending on if there is magical thinking? What else?
Social phobia.
Social phobia, right? What else?
Social anxiety.
Social anxiety disorder. Yeah.
General anxiety.
General anxiety. So you were talking about the anxiety disorders.
Mm-hmm.
What other personality disorders?
Avoidant.
Avoidant personality, right? So what differentiates, and this will come up on a clinical vignette, what differentiates the avoidant personality versus the schizoid personality when both may present with shyness?
Avoidant people, like, they want to have social
Right.
relationships, but they're afraid of, like, judgment, whereas schizoid people don't have any interest in social relationships.
Right. And the individual with schizoid is content with the isolation
Yeah.
and the social distancing. That said, on clinical vignettes, when they do present to clinics, it is often not a self-referral.
Mm-hmm. The schizoid.
Correct.
Right. It's like a parent or a family member that brings them. Right.
It's usually a third party. That's the hint. The avoidant, like you said, is conflicted. They want to be out there, but they can't overcome their own prohibitions.
Right.
So that conflict will usually result in a self-referral.
Mm-hmm.
Okay. Now, let's talk a little bit about that process. I want to put myself out there, but if I do, I might get hurt. Right? Avoidant personality. So if I don't put myself out there, I won't get hurt. Right? So they live by the creed: it is better not to have loved at all than to have loved and lost. That's their creed. And their avoidant behavior results a day later, a week later, reflecting back, hey, I wasn't hurt this week. So the behavior persists.
Mm.
What form of learning is that?
Positive reinforcement.
Positive reinforcement, right? So explain to me why positive reinforcement. First explain to me why reinforcement.
Or I guess it would be negative
Right.
reinforcement,
Right.
because they're not getting the punishment.
Right. Right. Reinforcement strengthens behavior. In this case, strengthens their avoidant behavior. And something is removed from the situation. That is, they're leaving their home or engaging in some relationship. So it's negative reinforcement that promotes avoidant behavior, that contributes to a perpetuating factor of avoidant personality disorder. Good. Let's talk about this anxiety disorders. All right, let's talk about the anxiety disorders. The anxiety disorders are now categorized in three separate sets, three separate chapters of the DSM. We have the obsessive-compulsive and related disorders, which of course includes OCD and other disorders related to OCD. Trichotillomania is an example. We have the trauma and stressor-related disorders. That includes post-traumatic stress disorder. We're not going to talk about that. We're going to talk about the anxiety disorders proper.
Mm-hmm.
Okay. So PTSD, we talked about earlier today. That's Dolores Claiborne. We talked about aspects of obsessive-compulsive disorder as well. Now we're going to focus on the anxiety disorders, all those disorders that are left over, that are not obsessive-compulsive or related, that are not trauma or stressor related. So, the patient comes to you with evidence of avoidance behavior that you deem to be clinically significant. We already talked about a differential diagnosis, right? Now, unfortunately, when your first two lines of your shelf exam convey this, you are not to look at answer choices just yet, because I could guarantee you every answer at this point will make sense. Right? So, there's a couple things I want you to do to prepare for the exam next week. Number one is you have to be able to list these disorders before taking your exam. If you don't know what they are, you can't list them, then you're already behind the eight ball. Number two, once you can name those disorders, the second step will be to identify one or two characteristic things for each that helps differentiate one from the other. Find those in your vignette, go to that specific answer, and then move on. Right? That's the way to actually plan and strategize these anxiety questions on standardized tests like the Shell. Okay? I posted the acronym for the list of anxiety disorders on Instagram. Somebody want to bring that up? And it fits perfect. Hopefully the picture made it on Instagram as well. It fits perfect with the discussions we've been having specifically to not only The Shining, not only The Thing, that they were recommendations for the weekend we were snowed in, but also here as well, both Dolores Claiborne and even Little Shop of Horrors, right? That's the drab APO, APL, right? A way to describe a solar eclipse.
Where did you post?
Yeah.
Should be on Instagram.
Like
On the which page? Art of UJ Psychiatry?
or in
No.
Oh, the first one.
The psychiatrist one.
Is that it? You see it?
I don't see it, but is it this?
Yep.
This is it.
Not yet. Maybe the Instagram group didn't post it yet. Want to text them?
Sure.
I don't see it.
This thing? Diagnosing
Is it-
characters and little
Not yet.
horrors.
No, it's not here.
All right, well, we'll get that posted for you. So it'll be posted before your exam, I promise you. All right, but I want you to keep to that acronym to allow for a list of those anxiety disorders. And let's talk about those that apply to our character right here. That is those that are likely to present with avoidance behavior. So what do you have?
Agoraphobia.
Good, agoraphobia. What else?
Specific phobia.
So specific phobia, probably lowering our differential. What's and before we leave this condition of specific phobia, what is it? What's the definition?
It's where you have anxiety like sort of caused by one specific situation or object.
Good, good. Now, the good news is that for people taking standardized exams, way back, we used to have specific names for each specific phobic object, right? Triskaidekaphobia, etc. Samhymnophobia, etc. You can look them up. But the fact is that those will come up on exams, and you have to pick what the heck we're talking about. The good news is that the American Psychiatric Association has really simplified this and created 4 different general groups. And if your patient doesn't fit in either, then other is the grab bag. What are the 4 groups?
Animals.
Good, animal.
Blood and health or
Good.
something.
Blood injection injury, good.
Natural disaster.
Environmental, good.
Environmental.
Yeah, 3 of the 4, and 1 more.
Heights?
Good, that's the example of situational.
Situation.
Yeah, that's it, there are your 4. And again, for some reason, the American Psychiatric Association found a way to get the most, I think, common one of clowns and not have that fit. Right, so there is a grab bag called other. I very
Not
much
like animal.
Can't fit it in.
You really can't fit that in. It is very unlikely that specific phobia, comma, other is going to be a single best answer on your shelf exam. However, in clinical practice, don't dismiss it, because you may have somebody present to you with a fear of clowns. Right? Those people do exist.
So heights is situational, not environmental.
Correct. Environmental is storms, lightning,
Okay.
floods.
Where a situation would be like heights, airplane rides and stuff like that.
Mhm.
What would claustrophobia fall under?
Situational.
Situational?
Yeah, situational.
I guess you could be in a situation where there's a clown.
Yeah, I looked at that too. You could also be, with a clown at 34,000 feet too, and that could be a
Fear of
height.
circuses.
Again, it'd be difficult to manipulate that round peg. So. All right, so a person presents to you with evidence of avoidance behavior. What I want you to first consider is whether or not the condition is exacerbated by where they're separating from versus where they are going to. Right? You have to make that differentiation. If it is revealed that it's more from where they're separating. An example of that would be that you have a demonstration of anxiety when the individual is leaving for school, and when they also leave the house for piano lessons, and when they also leave the house for practice. It's less likely that it's each individual destination that is the hallmark of anxiety, but the common variable of where they're separating from. Answer A, normal, is that very scenario when the individual is about 12 to 18 months of age, because separation anxiety is actually developmentally appropriate at that age. So normal behavior could be the single best answer here. It is very unlikely that the board will have somebody who is 19 months age, right? Just outside of that peak. Instead, think 9 years, 11 years. Okay, it would usually be a child, right? 70-30, 9, 11 years of age. Anxiety might also be manifest as tantrums, behavioral, or even somatic complaints, headache, stomachache, right? So all of that equals operationalized as anxiety. If it's where they're separating from, separation anxiety disorder will be the single best answer. On the other hand, if it's more a product of where they're going, you have a second question to ask, and that is why. If it's the social situation itself, you're dealing with social anxiety disorder. Most common example, performance of some type, aka performance anxiety. Performance type is now a subtype of social anxiety disorder because of how characteristic and common it is. If it's not the social situation, but fear of becoming symptomatic and therefore incurring embarrassment, we call that agoraphobia. Okay. Now again, public speaking is the most common form, subtype of social anxiety disorder, aka social phobia. Let me give you the clinical vignette just to impress upon you how important it is for you to read the question carefully. Professor reports to you with a chief complaint of anxiety. After full psychiatric evaluation, they tell you that when they get behind a podium of an M2 class, their anxiety peaks to a point of having a panic attack. When asked, they tell you that because of where the podium is set, escaping from that situation upon becoming symptomatic due to their Axis 3 diagnosis, medical condition, whatever that might be, will result in significant embarrassment for them. Most likely, or what is the single best answer?
Agoraphobia.
Agoraphobia. Even though it's presented as performance, right? Public speaking.
Is it because agoraphobia is like you feel like you can't escape from that situation?
Exactly right.
Is that like the key word?
Exactly right.
That's the definition, yeah.
Yep, exactly right. All right, so that's something to consider here. Okay, it could be normal behavior when age appropriate for separation anxiety, 12 to 18 months of age, or it could be abnormal behavior if separating from is what is most concerning, is the impetus, is the cause. We're dealing with separation anxiety disorder. If it's where they're going to, depending on what their fear is, it could either be social anxiety disorder versus agoraphobia. All right? Any evidence of this in Seymour?
He seems pretty nervous whenever he's leaving the plant shop. Like when he went to the radio station or the dentist office, he was like very fidgety and like restricted.
So some level maybe of separation anxiety, or more specifically separation anxiety disorder. Right? I mean, he's clearly older than 18 months of age. So that may be a differential diagnosis. So we start out with perhaps schizoid versus schizotypal personality, but I think that social anxiety disorder has to be in a differential as well. Any additional observations
I wonder about the social anxiety disorder because sort of the whole thought process behind this, bringing this cool new plant was to get more people to come into the shop, and then they had like all these TV people and like interviewers. So like that fame was sort of like a goal. So maybe like someone who has social anxiety like wouldn't go trying to get that.
Well, two things, two thoughts here, and you're right. So this begs more questions. So let me pose two questions. Number one is, as it does draw more and more attention, what do you observe and see more?
Oh, you like decompensating.
Does he?
more.
I don't.
Yeah.
Right? He might. Right. So that might be indicative or supportive that this, in fact, is social anxiety disorder. Now, of course, as a psychiatrist, you have to ask the question: if you understood this, why did you do it in the first place? But there does seem to be some monetary value to this, right? So there was another motivator here. There was a second thought I had about this as well, and that is what we talked about before, and that is maybe the plant doesn't even exist. So if he does this to draw more attention to himself, well, we already said that the plant is just an externalized id, and there you go. That explains why he would do this, because that's his impulse. That's what he wants to do. So that is consistent with, albeit another alternative view of what's going on in this film. So that's two possible answers. But you're exactly right. And someone we're entertaining the single best diagnosis of social anxiety disorder, the psychiatrist would inquire here. This, on the surface, perhaps does not make sense. Other thoughts about Seymour or now any other characters? Want to talk about the triplet?
About who?
Audrey.
Audrey.
Oh. The plant. Is that a character? I mean, it
So,
is.
let's talk about Audrey too, just so we can close with, I think, a point that I want to make in closing this discussion about what the Little Shop of Horrors is really about. So, where does our thought process start?
With Audrey too.
Yeah.
It's definitely like a very like gluttonous, a greedy character. All he wants to do is get more and more and more, and then like spread.
Yeah.
Antisocial.
Yeah, I don't think there's any argument that there's a blatant disregard for and violation of others' rights, right? So let's actually go down that road and say, well, this looks like a sociopath or even psychopath, right? What might we then consider? And this will be the final teaching point we review then. What might we want to consider then that kind of undoes our train of thought right now? So
Well,
think
if
of
it's
the-
like not its own character.
Well, it is. Let's say it is.
Oh, okay.
For the sake of this
Oh,
discussion,
okay.
let's say it is.
If it's someone's like displaced id that's not actually doing real things.
No, let's say it's real. Let's say somehow at Rutgers RWJMS, you're having to provide a psych eval on a plant.
I honestly wouldn't put it past our schools.
Our Department of Psychiatry does use unique teaching tools. Some okay. And some people, upon hearing this, actually match here. Right? So think of the routine psych eval. What are the different components? And let me re-ask the same exact question. Think of the routine H&P. Tell me what information you're going to gain in an hour.
You screen for depression, bipolar anxiety.
So past psychiatric history.
Yeah.
What else?
Past medical history.
Past medical history. What else?
Family history.
Family history. What else?
Social
HPI.
history.
HPI. What else?
Substance
Social
abuse.
history.
Social history.
Substance.
More specific.
Substance use.
Go on.
History of like abuse, like social support system.
Okay. Audrey 2 says no substance use. Cage 0 out of 4. No illicit substances. No recreational substances, including cannabis. No ID DU. Okay. What else?
Does she have any like medical medication?
Now, social history.
Like living situation.
Living situation. Okay. Fine. I live in a store. Storefront. What?
Family situation at
Family
home,
situation. Okay.
Social support.
Social support. Okay. I've been living in the current town for X number of days.
Where you work.
Where you
There's
work?
no,
I don't
like,
work. I'm employed.
past history.
What do you mean?
like the plant just showed up, like, and it came from another planet. So like we don't know.
There we go. Don't we routinely ask our patients? You know, where did
Like-
this particular plant emigrate from? Deep space? Do we want to know what her culture deems as appropriate behavior? What is normative? Of course we do. And if it's the annihilation of humans, this might be a culturally Down syndrome.
Yeah.
Also, like, she's just trying to stay alive.
Don't they have those plants in like Mario?
Yeah. There you go.
Yeah. By the way, the plant is actually introduced in the lyrics of the Rocky Horror Picture Show too. Right? The Night of the Triplets is in the opening song, Midnight Double Feature, that introduces the film, the Rocky Horror Picture Show. The triplet itself is in Little Shop of Horrors.
Oh, that's the plant. That's what it's called.
Triplet, yeah.
Oh,
Yeah.
cool.
Have you seen? I might get this wrong. The Night of the Triplets is the original. The Day of the Triplets is the sequel. Old time horror movies, like B horror movies, classics. Again, in the lyrics of Midnight Double Feature, the first song of the Rocky Horror Picture Show, right? The lips.
Mm-hmm.
It just wants to survive. Now, when you said that, it reminded me of another alien film where someone with that insight verbalized it and it becomes obvious. Any alien, what's the alien film I'm referring to here? Where
Verbalize what? That they.
verbalize that here we are now at this point shooting at aliens, but all they were doing is being normal aliens.
Is it aliens?
It
Yeah.
reminds me of, I don't think this is where you're going, but of How to Train Your Dragon.
No. Men in Black.
Oh.
Right, when they're actually going through the actual training, Will Smith's character actually says, this one's just working out, right, etc. They're just being aliens. Yet, AF and Army personnel are putting bullets in them, right? So, very similar perspective, insight in terms of this triplet. We want to know more about their culture. Right, so what differentiates a culturally bound syndrome from culturally sanctioned behavior? First of all, what unites them? What's the common thread here?
It's culturally specific.
Yeah, so the behavior localizes to a geographical area, okay? And for test-taking purposes, that geographical area is usually, 90% of the time, outside of your practice. So it's somebody usually from a different country, or in this case, a different planet. Right? That's the commonality. What differentiates one from the other?
A culturally bound behavior is behavior that is like normal to the culture, but someone outside the culture may think is unusual. And a culturally bound syndrome is behavior that within the culture is abnormal.
Exactly right. And at this point, I don't think we know. Okay? I don't think we know. Now, it also begs the question, if someone comes from a different culture, deep space, and is doing what they're doing, that we see, we observe Audrey 2 doing, are we still going to pathologize it, or are we still going to intervene? I'm going to leave that question as a heuristic. I'm going to just leave it out there. Would be definitely in our differential diagnosis. Okay. All right, we'll leave it there. Any final questions or thoughts? Great. All right, thank you.
Thank you. You get any conflicts?